Have our little security stuffies as we're up here chatting with our little guys. Hello, everyone. Welcome. We are so thrilled to be here. My name is Taylor Macy, and like Samira said, I am an NMOSD patient and an ambassador for the state of Utah for TSF. And I am delighted today to be able to facilitate this conversation to help us understand a little bit more about rare neuroimmune conditions. And I think it's so special because one of the most important parts of feeling empowered in having a rare disease is understanding it in a way that is simple. And I think that is something that TSF does so well with really just distilling things down to make it digestible for all of us patients and caregivers. So I really am delighted to facilitate this conversation today. I would love if we could just begin with a brief introduction to each of you and what you specialize in.
Okay, yes. Hi, good morning, everybody. I'm so excited to see you. My name is Annette Wundes. I'm a neurologist. I specialize in MS and related disorders, and I work at the University of Washington.
My name is Gloria von Geldern. I'm a neuroimmunologist also at the University of Washington, seeing a lot of these diseases that we're talking about here today.
Hi, my name is Pavle Repovic. I'm a neurologist at Swedish, and I work at the Multiple Sclerosis Center there. And like my colleagues here, I also see people with disorders like NMO that are similar to NMO but different. I'm happy to be here.
And you've already heard me speak probably too much. I'm Shuvro Roy, also at the University of Washington. I take care of patients with all of the disorders being represented today, and then from a research standpoint, particularly involved in NMO, MOGAD. Fortunate enough to work with the Stiff Person Syndrome Research Foundation and then the Neurosarcoid Research Consortium.
Fabulous, thank you so much. We are representing a grand population of different neuroimmune conditions today, and what I would love to do is have a brief overview of each in order to help us as patients with a specific disease understand, but also to help us understand some of the more tangential conditions, how they differ, how they are similar. So we are representing today autoimmune encephalitis, CNS vasculitis, NMOSD, MOGAD, Neurosarcoidosis, and stiff person syndrome. So why don't we begin with autoimmune encephalitis? Would anyone like to give us a brief overview of what that looks like?
Sure. So I'll give it a stab. And so the thing about all of these conditions is that we as MS docs usually take care of them, but that's mostly because no one else is out there to do so. And of all the different subspecialties of neurology, ours is the closest one, our MS angle, is the closest one to what these rare conditions have. Autoimmune encephalitis, by its incidence, is probably close to the infectious encephalitis, about 1%. The challenge is that it comprises maybe dozens of different disorders characterized by immune attack against a portion of the brain. Some molecule somewhere expressed in the brain becomes the target of the immune attack. And even in the 15 years that I've been a neurologist, that field has actually expanded with the discovery of more and more new targets of that immune attack. Autoimmune encephalitis, to some of you in the audience, may be obviously familiar from your personal experience, but to most of the lay public became popularized with this book, Brain on Fire, and the Netflix, I think, show on it, that highlighted what happens to these individuals most of the time, that out of the blue, they develop often a range of inexplicable neurological symptoms that start sometimes with psychiatric, manifestations that are just out of nowhere. And so they may not even start their journey with a neurologist. They might start it with a psychiatrist or with a gastroenterologist or somebody else, and it takes a while to recognize that this is what it is. These diseases, autoimmune encephalitis, are in themselves, like I said, a basket of individual disorders. Their manifestations are really complex and different. There's a lot of overlap with other parts of medicine. There's psychiatry, there's seizures, there's sometimes gastrointestinal involvement, sleep disorders, movement disorders. So it tends to throw doctors for a loop when a patient like this presents. I could talk on about this for a lot longer, but as far as the introduction, I think I'll just stop there.
That's great. Now, CNS vasculitis.
I can comment a little bit on that. And I'll maybe talk about both CNS vasculitis and neurosarcoid, because what they both have in common is that they can affect the brain, obviously, and that's why we as neurologists usually take care of these patients. But they can also sometimes affect other parts of the body, and they're difficult to diagnose because to be really, really sure that somebody has this disease, you need tissue, you need a biopsy. Which is challenging because it might involve a biopsy of the brain or the meninges, so a surgery of the brain. It might involve getting tissue from somewhere else. In the case of neurosarcoidosis, sometimes you can do a biopsy of a different part of the body, and then you assume that you're dealing with neurosarcoid because you think that this disease affects different parts of the body and might also be responsible for the symptoms in the brain. But you're really only sure when you do a biopsy of the brain tissue to know that this is what you're dealing with. So that's one of the challenges that these two conditions have in common. They're also rare. All of what we're talking about here today are rare conditions, and so it can be challenging for patients to know where to find help and to get the right diagnosis, and it can be challenging for physicians because it's not something that there's thousands of people to study. It's not something where there's clear FDA-approved medications, and so that's probably a common challenge actually for all of these conditions that we're talking about here today.
Thank you. And NMOSD and MOGAD?
5 minutes of microphone, maybe I jump on this. Yeah, so this is a disease which only over time we identified to be different from MS, and in the old days were probably all summarized as part of likely having MS because there are some similarities, that there are relapses, people suddenly get symptoms. There's also an overlap in terms of what type of symptoms people have. So for instance, optic neuritis, probably several people in the room know what that is, when suddenly there's blurry vision or loss of vision because of the inflammation of the optic nerve, or transverse myelitis, where the immune attack targets the spinal cord and causes damage and symptoms related to that. So MS, MOG antibody disease, and NMO spectrums disease all can cause that. And before we identified that there's a subgroup of people who have particularly bad episodes and have particular bad residual symptoms, so once they get better, the tendency of getting better or recovering from these relapses is not so good than the average person with MS. Over time, that was then identified to be actually a very distinctly different condition, even though there's an overlap with the MS. And the antibodies, no, I'm a little bit shy on memory when exactly that was, but I believe 2004. The antibodies against NMO were identified, and then one was MOG, maybe 2017. Okay, I would have been correct there. And so this is something which is fairly recent. So I have been in MS care all along. So I've been in MS care since before we knew about the antibodies from NMO. So this is something where we have learned a lot over time. And through the inspiring story we heard earlier today, we can see how much has happened since.
Fabulous, thank you. Stiff person syndrome.
Yeah,
Dr. Roy?
so I can certainly speak to that. And, fundamentally, we still don't exactly know what causes stiff person syndrome. We know that there are certain clinical characteristics, and we wrote, multiple papers on this recently of, fundamentally what we tend to see in patients is that they have these striking symptoms, and this can be both gradual as well as having acute attacks of stiffening and spasms and rigidity of usually the limbs and then the lower back and abdomen area. With that, we have identified that at least most of these patients have an association with a certain antibody called GAD65. We still don't exactly know how that acts directly on the muscle to mediate this condition. And we know, if that's not confusing enough, there are also many other conditions that can be associated with GAD65. And while when that condition was first described in 2001 as being associated with GAD65, we've since found that actually there are maybe 3 other antibodies that may be associated with stiff person syndrome. And on top of that, each of them carries their own little quirks of how they may present, whether greater involvement in the upper extremities or associations with even certain types of cancer. And of course, this is another condition similar to Gloria's point, where we have a long ways to go in terms of clinical trials and treatments that we are trying to identify. And then on top of that, also making progress in just helping providers better identify this condition and unfortunately some of the stigma that's associated with it.
So I think what we have well established is that these are each individual conditions with a lot of overlap. And so what I am curious about is, how do you approach the diagnostic process when there is so much overlap? I know it was briefly spoken to in terms of like biopsies and lab markers, but I would love to dive in a little bit more into how you begin the differentiation process to figure out exactly where to land.
Maybe I'll start with something that's extremely simple, but really, really crucial. Any diagnosis of any of these conditions really starts with sitting down and talking to the patient and getting a really good history. And I've heard before, and maybe you have too, that diagnosis is a journey. And all of you probably have some experience of a longer or shorter journey to the right diagnosis. But really the key is, first of all, to really try to understand the symptoms and the time course and exactly what's been going on, and getting a good history, sitting down and taking the time to understand that. And in that goes things like, what other things in the body are going on? Are there gastroenterological things? For sarcoid, is there any problems with breathing, any skin problems? So there's not just neurological symptoms that we need to ask about and know about, but other things that can give us clues in terms of what tests to do or what to look for, whether people have relapses where they have a neurologic symptom that then gets better or goes away, really understanding the story.
I just want to take you back, actually ask you for a little thought experiment. In high school, in high school, I took a class in philosophy, and I was bored out of my mind. I ultimately ended up doing a lot of science, medicine. I never thought all those ideas that I would have learned in that class would come in handy in my clinic, but they did. So bear with me, I'll explain how. Put yourself in our shoes. You're trying to be a detective. You're trying to diagnose, what does this person across from me have? All you know is patterns. If those of you are, maybe some of you may be familiar with the parable of Plato, with people in the cave, the parable is that you cannot see the truth, but you can see the outlines of it, because you're like a person in a cave who's only looking at the wall at the back of the cave, and the truth is behind you, and all you see is a projection of that on the wall of the cave. So if you're trying to discern those patterns, who is, for example, the person behind you, and you have an Uncle Milton who wears, punk hair and is very distinct looking, chubby, whatever. And he comes across, you're like, oh yeah, that's Uncle Milton. That he looks, he's very easy to recognize. And if you have somebody who's not that easy to recognize in your family, then you were like, maybe that's, cousin Ben, or it could be, I don't know, brother, whatever, Peter. So we as docs try to look for those patterns. We look for those shadows in what's sometimes very misty and kind of foggy room. And we're trying to pick out things that are typical. So for those of you who are seropositive NMOSD, in a very odd way, you could think of yourselves as being a little bit fortunate in that we know exactly what you have. For those of you who are seronegative, we're in the fog. We think we know what you have, but we don't know exactly. If it helps you any, your much larger community of MS patients are very much in the fog. We don't know exactly that they have MS because there is no diagnostic single test for MS. It's this constellation of findings that you try to put together. Here's another analogy, sorry for mixing them. Like beyond reasonable doubt, you're really trying to build a case that somebody has MS or some of these diseases that don't have a pure diagnostic test. And if enough pieces fit, then you go with that. So where this all ties into our rare patient day today is that everything we know, all the patterns we know, come from studying people with that condition. When a condition is very common, the patterns can be easier to spot. If you see that every person with a condition X cannot see, then you realize, okay, condition X causes vision loss. Or, I'm using a very blunt example, but if they all have blonde hair, you can say, being blonde may be a risk for condition X. So you start to see these patterns much better when you have a large number of individuals with that condition, which is why studying rare diseases like NMOSD, like sarcoidosis, CNS vasculitis, and so forth, is so challenging because it's so hard to find a large number of rare conditions in one place. This is, I think, also where NMO community led the way, bringing people with this condition together to sort of drive this process of discovery, which has been iterative, right? You know what you have, how do you treat it? You try one thing, you try another thing, you look back, you compare notes, you bring the community of clinicians who do this together to compare notes, and hopefully those patterns start emerging. What is this condition? What is the best way to treat it? And how can we help? Right, so I'll just stop. I'm sorry, this was pretty long.
No, that's fabulous. Thank you so much. And I think this is an important illustration of why it matters that patients participate in trials. As you are learning as physicians on that end of the spectrum from your patients directly, being in a rare disease community, we don't necessarily have large clinical data, and we are the trailblazers of trying to accrue that and build that for not just ourselves, but for the population as a whole. How do you all navigate treatment plans and helping your patients with currently more of a lack of clinical trials and clinical data? Which it's changed so much, thank goodness. Things are really going in the right direction. But how do you go about that when data is more limited? Dr. Roy?
So what I would say is I think oftentimes it involves, phoning friends, for example. I'm glad Gloria led our discussion on how do we diagnose patients. She leads our neuroimmunology board within the University of Washington. But when we are trying to figure out, for example, somebody who may not have a clear, diagnosis or may not have an established diagnosis, you're often discussing with others to at least decide, okay, well, what do we think is both going to, cover, say, maybe a spectrum of disease and also not cause harm based on other conditions that could still be in the differential. Other things that we thankfully have made advances in is the ability to collaborate with other institutions. So, for example, I use our community here in Seattle as an example. We are quite fortunate to collaborate with Swedish, with many of the other institutions in the area in both patient care, but then also we work with groups around the country to try to create the samples that we need to then have better answers with regards to treatment. How do patients do better with certain approaches? An example I'll use is in Neurosarcoidosis. There was a great paper that was recently put out where there are something like 35 different authors from all over the country essentially outlining, well, you know what, as we have put our clinical expertise together and completed something called a Delphi survey, which I know the Sumaira group is doing something similar for NMO. Here are what we recommend in terms of different approaches based on different phenotypes of neurosarcoidosis, which in and of itself is a huge advance from where things used to be, where it'd be like, okay, well, there are essentially 4 different treatments that we could try. We could try multiple. We could try 3 of them at the same time, and and there wasn't as regimented an approach as there is maybe a little bit more so now. And so putting our heads together, putting these larger cohorts together, I think is quite important in terms of establishing that, even if we don't have a quote unquote FDA approval. I'll stop there.
Can I maybe add one little thing?
Please do, yeah.
And I think exactly what you said, working together and keeping an open mind. So I think it's really important, and I know that's hard sometimes for both us as treating providers and for patients, to say, this is what we know so far, and we are hopefully learning more, and there is a little bit of uncertainty that we're left with, and to keep an open mind to change things. As we're learning more, for example, about MOGAD disease, we now can diagnose it better. We see more and more patients who have this disease. Maybe in a year or 2, we can tell you something different. And that also includes stick with it. Don't give up. Keep checking in. We have new treatments that come out. And so I think living with that, both diagnostic uncertainties to some degree sometimes, and living with that treatment uncertainty is hard, but it's worth it because we're learning more and more.
I piggyback on that yet a little bit more. I think there's also clearly a shared decision making in that, especially if we don't have a very clear cut, you have diagnosis X and the best treatment is treatment A. So if we are in a world where we have kind of maybe some diagnostic uncertainty, or we have competing drugs which may have some pros and cons in itself, then talking with the individual across on an individual basis and take what sits best with you personally, what fits your other medical conditions, your sense of risk, adverseness, or certainty, what sits better. It's in a pill, it's an injection, it's an infusion. So there are a lot of things which play a role in this decision making, and partnering on an individual basis with one person, one doctor, finding a treatment plan is a very important piece of that journey.
I really appreciate how much there's a palpable sense of collaboration in this space amongst clinicians, patients, patient advocacy groups. And what I am curious about is the collaboration between doctor and a patient is such a powerful thing, and the patient might need collaboration with other clinicians and to build a care team. I would love to know what an ideal multidisciplinary care team might look like for one of your patients.
You, Annette, that is all you.
We have the luxury to work within a multidisciplinary care team. So we'll have basically our rehab doctors directly in the clinic. We have our rehab psychologist directly in the clinic. We have a vocational counselor, social worker. So we are kind of like, I'm very blessed to work with a really large team, which all have the same same goal in mind. We want to empower our patients. We want to help them to have the least amount of impairments and the greatest empowerment. So kind of like working with different providers within the clinical team. And I know that Swedish likewise has also multidisciplinary care. And then also working with providers in the community, because as lucky as we are here in the Seattle area to have large centers, not all of our patients are living here. So some patients are living far away. And so kind of like partnering with their local care team is also part of our duty and service.
And then, of course, sorry, I'll add one more thing. It depends on the disease. So somebody with sarcoid needs a pulmonologist involved, a cardiologist. Somebody with CNS vasculitis might need a rheumatologist involved. So sometimes it also depends on the disease of who you need to take on board, and having a network of providers that can work together is really crucial, I think.
And just one small thing to add, again, keeping the focus on the rarity of these conditions. As somebody who's involved in clinical care, but also research, including translational research in neuroimmunology, I just wanted you to be aware that there are sometimes unintended consequences of the best intentions. What I'm driving at is that when you do medical research, when people do research on blood samples, spinal fluid samples, tissues, there are a lot of guardrails to prevent abuse and misuse of those samples. And sometimes those guardrails can be a little onerous when you are trying to study something that's very rare and uncommon. If you had an idea to study everybody with seronegative NMOSD and collect their blood and keep it in a freezer and just test it like 1,000 times over, you really can't do that. It's very hard. You have to have an idea, you have to plan, you have to get a lot of consents, you have to sign people on, you have to have the expiration date of how long you're going to be looking at things. And after that, all this painstakingly collected effort gets thrown out because there is an expiration date for everything. Sometimes I wonder if rare disease community would agree to this approach, which is perfectly reasonable in conditions like diabetes or heart disease or certain types of cancer that are far more common. I feel that sometimes people with rare disease feel abandoned and alone, and sometimes all these various guardrails make them even more alone on the research side than they need to be. So the one person I'd like to add to this multidisciplinary care team is that somebody toiling away in the lab trying to figure out, why some treatments work really well for some people and not for others, and what disease does this person who doesn't fit into any of the known categories really have. So initiatives like these to change the guardrails, to facilitate research in rare conditions, they can't come from us as doctors because we are, the party that does not own these samples. They come from patients, from people who agree to do these sorts of projects. So something else to think about.
To speak to clinical data, I would love to know, if resources were not a limitation, what type of studies you would love to see in the world of rare disease.
I was going to say, I mean, I can start, Pavle, if you want to start.
Say this diagnostic journey that all of you are on. Some of you have reached the point where you know exactly what you have. Some of you are still in the fog. I think that would be the one place where it really would, this entire community could help find answers. We often hear the story that the answer is in the patient across the table. Like, yes, it is, but how do we get there? Sometimes through just careful history collection, but this is the day and age of biological discovery. These answers are there. They are scientific. We just, I would say that would be the one I would.
Yeah, and almost to Pavle's last point, I certainly have my list. I can pull out my Trello app on my phone of just every research question and idea that I have related to, for example, better diagnostics for neurosarcoid, prognostic markers and MOGAD. How can we tell who's going to have a relapse, who's not, so on and so forth. But I think honestly, just as relevant is questions from patients and what are the relevant research questions there. Obviously we're at a TSF event, but the Sumaira Foundation does such a fantastic job of trying to gather that information. I serve on a council alongside patients of, okay, what are the relevant research questions that we need to answer and how do we design studies to do so? Same thing with the Stiff Person Research Foundation. It does an outstanding job of incorporating both patient and physician voices. I hinted at it maybe in the welcome, but especially as we have all of this uncertainty, just in our federal funding system, I think it becomes more and more relevant to work alongside patients to develop the relevant questions that can help us as providers, but more importantly, what is going to change your quality of care and your quality of life long term, and then work on how we can solve those questions together, whether it is observational studies, whether it is something more involved, whether it is sample collection. I think that really does require a collaborative approach.
The world of rare disease can be so isolating, and what has impressed me so much in hearing these discussions, and also just in patient days in general with TSF, there are people that care, that are working actively to support these conditions, to find solutions, and I hope that is something that is evident and that you can take with you in those moments of feeling isolated, feeling like things are hard, because they do get so hard sometimes, that there are people that care, there are people that are working actively and that care for individuals and their well-being. Before we open it up to a Q&A to ask our panel up here, I would like to ask a final question. What have you found distinguishes your patients who do the best clinically and emotionally after diagnosis?
That's a big question. So I'm just going to ramble now. No, I'm just kidding. I think, I think, it's funny. I feel like, and I'm curious what our other panelists think, but I think oftentimes when we are making these diagnoses with patients, yes, you make the diagnosis initially, and then you spend the maybe next couple of appointments just even rehashing, what is this? How do you even pronounce neurosarcoidosis, or what is stiff person syndrome? And Pavle hit it right on the head at the beginning here, where I think patients who generally, for example, I'll use SPS as an example because it's a cause close to my heart and involved with many of the initiatives there. It is a condition that is remarkably challenging to treat. We have limited clinical trials thus far in terms of immune therapies. It demands a lot of what we call GABAergic medications, which in their own way can come with many side effects. And yet, of the patients that I care for with SPS, I'm really blown away at just the attitude. Oh gosh, I'm getting emotional. I'm blown away at the attitude that you all seem to bring to every single one of my appointments, because you are always so positive. And I think it's because so many of you are connected. Some of my patients will mention, like, oh yeah, do you know so-and-so? I'm like, yes, another one of my patients. Yeah. And you are all connected in that way. And I think, it gets to the crux of what are we doing here, of, we are all working towards a united purpose of, treating these disorders and finding answers over time. So I think there's that. I think folks who are not just emotionally, connected with one another, but also just quite physically active. Obviously, there are limitations that these conditions all place on our patients on that end, and in some way take some piece of identity from each patient, but holding on to that identity, whether that's continuing to engage in what you can, and pushing your body as best you can. I find that those are the patients who, in my experience, tend to do quite well. But I'm already rambling, so I'm going to stop.
I'll add one thing. You said community between patients, and I think that's very important. But I want to give a huge shout out to the families and caregivers of patients, because I think they make a huge difference.
I couldn't agree more, and they deserve just as much attention as the patients do. I would love to take this time to open up the panel for questions. Does anybody in the audience have something they would love to know from our wonderful panelists up here? Sure. Yep.
My name's Candy, and I am a patient of
Thank you.
I do have SPS. I recently made the decision to put myself into assisted living because I do not want, I'm single, my kids are grown, I do not want to put that pressure on them as the disease worsens. The problem I'm running into, and the I guess feedback I would like, is in the assisted living community, the nursing staff, the med techs, all of those know I have this disease. Not one person has gone out of their way to learn or know anything about this disease, which does not give me any comfort if I have a bad episode. Sometimes it takes them 20 minutes or longer to even answer the call button, depending on, what's going on. So I am running up against that now to where it's absolutely terrifying. And I don't know what I need to do to push the issue to make them, or to introduce them to wanting to do their job and learn about the disease if they've got somebody in their community that has this disease.
Candy, I don't mean to just immediately take that and apply it across many conditions, but I would bet just about every patient in this room has a similar story to tell, whether it's dealing with even a provider or dealing with, staff or, nurses, or you name it. This is something that, I'm involved in some medical education activities around the country, and we deal with this even with the most established of these diseases, seropositive, aquaporin 4 positive neuromyelitis optica, where patients are often misdiagnosed still with multiple sclerosis and treated with different therapies that would not be correct. And it's a question that we are constantly asking ourselves. Just even as providers, how can we better reach out to these communities and educate on these conditions. I wish I could tell you there's a simple fix other than, sometimes we just have to sit folks down and say, okay, well, here's how this works, and here's why it matters that we need timely interventions, or so on and so forth. But it is something that we're still striving to achieve. It's why I'm grateful that we have the patient advocate groups that we have to try to get further into those communities. But you bring up a really good point, because I think a lot of these initiatives are often even still targeted towards providers, but that's not necessarily the point of access of healthcare for every patient. And so I think that's a really, that's quite a valid point.
I just want to touch on something else you brought up, which is honestly not unique to any one condition, and that's being in an institution where you rely on other people to help. This, I have to say, is a problem for everyone. I have not heard of any place where the staff are just amazing all the time to every patient. As someone who has a close family member going through something like this, I can see that, medicine, medications, yeah, that's one level of helping them, knowing exactly what condition they have and what medicines they need for it, yeah. But then there's this other part of medicine, just the plain caring part, that can get lost in all of this institutionalizing. And from their perspective, this is just another person in the room, wheelchair bed, that they need to take care of, and there's dozens. It becomes a little depersonalized from them. And what we've learned from, again, this sort of personal experience is that people who have visitors, people who have somebody coming in, checking in, bringing a little something, talking to the staff, make a huge difference. So if you have somebody who is in this sort of an institution, make time to visit them. It makes a huge difference, not just to them, but to all the staff around them who see how much this person is loved and cared for. And that entices them to, see them as not just another name on the paper or a person. Like, they see them a little differently. We've seen that. We've seen a huge difference when the visits increased and what we call boots on the ground are there. So that's not a medical advice, just a human presence.
Well, thankfully, I have a very, very supportive family network here in Washington.
So glad to hear that. What other questions might we have? Yes, here.
Can I add an answer?
Sure.
I want to throw in an answer for you. I am a newly diagnosed SPS patient, but I'm also a community clinician that does home visits in facilities and patient care homes. And we see a lot of really rare diagnoses, things that even our doctors are like, I don't know, we got to look this one up, And one of the most helpful things that people have is something simple that they hand us as a clinician. Here's my diagnosis. These are the key factors, not like dense, not like 8 pages, because I'm not going to read that, but a 1 or 2. And if you're in a nursing home, those nurses have no idea on the most basic things, let alone the complex things. So being able to hand things to people that's not condescending, but it's condensed and it's simple and it's repetitive, and have a lot of copies and carry that information.
Such a fabulous piece of advice. We've got another question here.
Sorry.
My name is Kathy, and I'm an NMOSD patient. And a question I have, which I don't know if you even can comment on this, but my daughter helps me with a lot of research, looking for NMOSD. And she was looking, she said about CRISPR research. I'd like to know if you know anything to do with that right now. Anything new, anything.
The last couple of months?
Well, just whatever you want to comment about it. And I just
So the
like to know.
Cas9 CRISPR system got a lot of press in the last few months because a drug that uses that approach was found to be very effective in a disease called Huntington's disease. So that made a ripple through neurology, because this disorder, which is very different from the ones people have in this room, is caused by a genetic defect where there is a certain part of the genetic code that repeats unnecessarily long. And if you can cut that out, the repetitive part, then you may be able to prevent the disease. And so that's what they did with this trial. So they edited the person's gene using this therapy and were able to show benefit. For diseases like ours, we're not sure yet how to employ something like CRISPR. I'm not, I should just say, maybe, because the vast majority of our conditions are not genetic. Or we don't know that they're genetic, so that's the other part of it.
Thank you.
Awesome, thank you. We have time for one more question before we break for lunch in our group photo. Does anyone have something they are eager to ask? Do we have?
Hi, so it's just a comment and then a question, but many of the folks in this room, they're living with rare disease. Some of them are lucky enough to be right next door to University of Washington or Swedish Medical Center, but many are living much further away. So the question I have for you all is, people that might want a second opinion, maybe another diagnostic attempt, maybe a second opinion on their therapy, they're often with general neurologists that may not have that much familiarity, that many patients with their conditions. How do they get in touch with folks like you? And by the way, I just want to say they're all very modest, but these are some of the best neuroimmunologists, maybe all of the top neuroimmunologists working on these rare conditions in Washington State. So we're very lucky to have them here, but these are very rare conditions and you really need a lot of expertise to handle them. How do folks reach out to your networks if they want a second opinion?
I'll comment on that. So we are always happy to see people that live far away for a second opinion. And we work closely with other neurologists, general neurologists, like you said, or primary care doctors even in more remote areas. So it does not mean if you come to see us that you have to keep coming back every month or so. So I have patients in Alaska, I have patients in Montana, and I work closely with their local doctors. So if you are not sure, or if you want another set of eyes, you can directly call our clinic at the University of Washington, probably at Swedish too, or you can ask your local doctor, and that's even more useful, to send a referral. That does not mean that you're going to leave your local doctor, or it doesn't have to mean that, because we work together with all these other providers very closely.
And then there's obviously the advantage of telehealth nowadays. And so kind of like there are some maybe insurance restrictions, so we are a little bit worried about that possibly coming our way. But kind of like it's sometimes very helpful to come in person for neurological exam, but many of the things we are doing, we can actually also accomplish with telehealth, at least in follow-up appointments. And kind of like sometimes there's, in our area, we have some providers who have telehealth privileges, even for Montana or Alaska, that we don't have you to come for every follow-up visit there. So that's a very important tool as well, and phone visits.
Awesome. Thank you so much. Let us extend a generous thank you to this wonderful panel today.